Dobbins here. Welcome to everyone for this webinar today on reproductive health program planning. I guess it's afternoon for some of us and still morning for others of us. If you are having any trouble hearing me, you can send a message to all the panelists and we can try to do a little bit of troubleshooting around that. We have someone monitoring that, and if you are having a fair amount of trouble, we have posted the help support number at the bottom of the panel and chat, and you should give them a call to have them provide further assistance to you. So today we're here to talk about the results of two Cochrane reviews on reproductive health, primarily related to breastfeeding, and another one related to nutrition during pregnancy. And I just wanted to give you a little bit of information about who we are as we get started. This is the team. I've just put that up there for those of you who aren't familiar with us. I'm Maureen Dobbins, the director of healthevidence.ca, and actually almost all of us are participating on the line today through this seminar. We have Cara DeCorby, Diva Trillis, who's been the key person coordinating this project. Lori Greco is a knowledge broker. Heather Husson manages healthevidence.ca. Robin Trainer, research coordinator, and as well as Lindsay McRae. So that's our team, a little bit about us, and I just wanted to spend a couple of moments talking about healthevidence.ca. So if you're not familiar, healthevidence.ca is a repository of systematic reviews evaluating the effectiveness of public health interventions that have been published since 1995. And what we've learned over the years is that it's actually quite difficult to locate this evidence in large databases like Medline, and so we're trying to bypass that need for frontline decision makers to spend time searching for the evidence by identifying them and putting all of these citations in one place. We also go one step further to assess the methodological quality of all of those reviews. So you can actually, when you go onto Health Evidence and do a search, would be able to see what our recommendation is on the quality of the methods of doing that, of using that systematic review. And the intent is really to help facilitate the integration of this pre-processed, appraised evidence into public health decision making as it relates to programs and policy, not in Canada primarily, as well as internationally. Just a couple more things. We really think and have heard that this saves time in terms of not having to search the databases, not having to do the critical appraisal. Everything on health evidence is directly relevant to public health practice, primarily related to how we would define that in Canada. So we did a very broad search across the provinces and regions to identify what public health services entail in Canada, and then from there created a list of what would be considered public health services, and then we search according to that. So everything that you find in health evidence is related to public health. It's related only to evaluating the effectiveness of interventions. So you wouldn't find, for example, anything related to associations between an exposure, for example, exposure to secondhand tobacco smoke and your risk for different cancers. So that's the causation literature that we have not included at this time, that reviews in that kind of literature. We hope that at some point we might be able to do that, but we haven't done that to this point. And we try to be as current as possible. So currently you will see anything that's been published, usually within the last 4 months, is up on health evidence. We try to keep to that timeline as much as possible. We have a very transparent process for how we search, how we decide what is relevant for health evidence, as well as how we assess the methodological quality. And on the top, when you go into Health Evidence site, if you were to click on the tag at the top that says about our strategies, about our process, you would be able to find there detailed notes about everything that we do and all of the tools that we use to assess relevance and quality and that process that we go through. We also recognize that just having access to pre-processed evidence, quality appraised evidence, does not all on its own lead to evidence-informed decision-making, what we call EIDM, that there's actually more support that's required generally at the frontline level in order to develop the knowledge, skills, and capacity to be able to use evidence in decision-making and practice. So we also have been developing various tools that we have also available on the site that really would be a direct resource and support as you would go through the steps of the evidence-informed decision-making process. So just quickly as an example, we would have some tools that would help you think about how you might go about starting your search to look for the evidence, and also documenting where you searched and what the results of those searches were. So that's also something you might be interested in looking at another time on health evidence. And we've also tried to listen to our target audience in terms of what the functions are they would like to see on health evidence. We've done a fair amount of consultation over the years across Canada at all decision-making levels to hear what users are saying about what would be useful to them. And one of the key things that we've learned is that it needs to be something easy to use. So we have tried to make it a resource that's easy to search. You can search it in multiple ways. You can use your own terms in a Google type of search, or you can also use our keywording tree and click on those to create your search strategy. We also have a feedback loop on health evidence. We're always happy to hear feedback on the site. Positive, of course, is always welcomed, but we also recognize that the best way to keep health evidence improving is to hear your thoughts on areas for improvement. So please use that loop and provide us with that feedback, and we do our best every year to address those concerns that come up. So we have here listed, you'll see a question. There's a slide here just saying questions. If there aren't any major issues, I would like to now just move on into discussing what we're all here to hear about today, which is the results of these two Creamer reviews. Okay, so we are able to provide this webinar today due to receiving a grant from the Canadian Institutes of Health Research that falls under the Meetings, Planning, and Dissemination Funding Competition. And we submitted a grant to CIHR about a year ago saying that we were interested in identifying reviews that have been conducted in Canada that have been funded either completely or in part by CIHR that are relevant to public health practice, and that we were wanting through this grant to have an opportunity to push this knowledge out to the frontline users. So we know that sometimes it can be very difficult to stay on top of the latest findings. And so this is a project that's now trying to identify who's working in certain fields and holding webinars to send this information out, and also to try to initiate discussion, debate about these findings and what that means for public health practice, how it can be integrated into various local, regional, provincial areas across Canada. So that's what we're focusing on today. The two reviews that we will be talking about, the first one was conducted in 2002, talks about the optimal duration of exclusive breastfeeding, published in the Cochrane Database of Systematic Reviews. And the second one, also by Creamer, published in 2003, discusses energy and protein intake in cancer, also published in the Cochrane Database. Now, one thing to point out here is that you will notice that they both have, they're a little bit old now, coming on 10 years old for both of them. We have been in communication with the author about this and are aware that reviews for both of these are being updated and that they expect updated versions of these reviews to be published into the library hopefully in the earlier part of 2012. So something to just keep an eye on. These reviews are definitely, it's time for them to be updated. And at this point, we're not aware of what impact the addition of new studies will have on these reviews. So today we are presenting what is in these reviews, but just keeping in mind that perhaps over the next 6 months we might see some changes to these findings. So right now, we're actually just going to take a quick poll of the audience. What I've just put up here is the first part of our summary statement that for Kramer 2002, and you'll see highlighted off to the left 4 words: population, intervention, comparison, and outcomes, which refers to PICO. So we're asking all of you a question right now that we'd like you to comment on. Who has heard of PICO before? And that is a yes/no answer. So we're just watching. Everyone who's participating, their answers are coming up for us. It looks like it's a close race. And so it looks like we're about 50-50 here in terms of half of you have heard of PICO and the other half haven't. So let me just quickly talk about that. PICO is, well, PICO can be used in 2 different ways. PICO can help us define a research question to help us refine our search efforts when we are now ready to go to databases to look for relevant evidence. And it also can be very helpful as a user of a systematic review to look for in the title or in the abstract or very early on in the review. You can be asking yourself, who is the population that's being studied in this review? What interventions are being evaluated? What are they being compared to? And what are the outcomes that are being reported on in this review? If you're a user of a review and you know for yourself what population, intervention, comparison, and outcomes are of interest to you, and you quickly look at a review to see what they've identified on the PICO, you can tell very quickly if this review is actually relevant for your issue, concern, or a decision that you're facing. So that's something very important to think about in terms of you don't want to waste time reading, actually trying to track down the full text of any piece of evidence if it isn't actually going to be addressing your question. So asking that very quickly, and a good review will tell you that either in the title or in the abstract, which would be, in most instances, freely accessible to you. So we use PICO to help us understand what a review is about, and then if you have an issue where you you find yourself needing to go to the evidence, the research literature, to gather studies and find out from studies what the answer to a particular question is, then it would be very useful for you to identify, again, what the population is you're interested in, and trying to be as specific as possible. What the intervention is you're interested in, maybe it's more than one, what you're comparing it to, and also the list of outcomes. It might be just one outcome. It could be more than one outcome. In the work that I've done so far with public health decision makers in Canada, this is actually, it seems like this would be a fairly easy part of the whole process of evidence-informed decision-making. And actually, I urge you all to say out loud in a sentence what your research question is, using these 4 terms. And sometimes in saying things out loud, we realize that maybe what we thought was very clear in our heads isn't quite as clear when we say it out loud. So it's really, really important to define those 4 components very carefully. And then once you've defined those, then that's the starting point for the types of keywords that you can use in your database search. And so that can actually help reduce some of the time that it then takes to figure out what the right words are that you need to include in your search. Okay, so we're just going to move on here and talk about the quality rating. So at the very bottom, of the slide now, you will see highlighted in red a little small section there that says review quality rating 9 in brackets strong, and then details on the methodological quality are available here. So what we're just trying to demonstrate to you is that this review has been evaluated for methodological quality by 2 independent raters at healthevidence.ca. So they're both sitting in their own offices reading a review and assessing the quality of the methods of the review, and they give it a rating, and then if there's any discrepancies in the rating that they both gave it, then they meet to discuss and come to consensus. The highest score you can get on our rating scale is a 10. So as you can see here, this review is a very strong review. Generally, Cochrane reviews are going to score very well on the tool that we use. And then what we've also learned over the years that Health Evidence has been, since the launch of Health Evidence, is that you're also interested in knowing how we came up with that score. So if you were to click on the word here, highlight the linked word, then that will take you directly to the actual quality assessment tool that we've used, and you will be able to see how we assessed each criterion, yes or a no. So I'm now going to start discussing what the overall findings were. And this is actually something also a little bit new for healthevidence.ca. Those of you who are familiar with our previous summary statements, we used to have the considerations for public health practice, so our overall findings we had much lower down on the summary statement, and we've actually now moved this right up to the front. So it's basically like reading the conclusions of a study or the last page of a book first. We understand that this is really, at the end of the day, the key message is what you want to see very quickly, and that's what we've done here. And we're also interested in hearing your feedback on the changes that we've made to the summary statement in the last little bit. So again, you can use the feedback loop if you have some specific information you would like to share with us. So I'm going to start by looking on the left-hand side of this table with what are the conclusions from Health Evidence. So what we've done here is we've looked at these reviews, and they're particularly this one on exclusive breastfeeding is fairly complicated, not fairly, it's a very complicated technical review. And we've really tried to condense into a small paragraph what the key findings are. Those of you who are familiar with this review will also know that this review presents results for both developed countries and developing countries. So there's data that has been done on studies from developing countries, and that has been reported separately. We will not be discussing that today. The majority of attendants on the webinar today are in Canada, across Canada. Perhaps everyone is, and we felt that it was most important for today to focus on the developed countries. But we have included in the evidence table below, so in the summary that's been written, we have also explicitly identified what the results are for developing countries. So EBF here refers to exclusively breastfed infants, and MBF refers to mixed breastfed infants. And the comparison here was exclusively breastfed infants up to 6 months of age were compared to mixed breastfed infants had exclusively breastfed till 3 to 4 months, and after that other forms of liquid and food were introduced into the diet. Generally what we have, what the review reports is that exclusively breastfed infants have an increased head circumference at 12 months. They have a higher hemoglobin concentration at 12 months. They have a lower risk of gastrointestinal infection, lower risk of otitis media, ear infections, and a small amount of evidence that suggests these infants crawl up to 1 month earlier than mixed breastfed infants. We also We also learned from this review that mixed breastfed infants compared to exclusively breastfed had higher weight gain at 3 to 8 months and also had some higher weight for age at 6, 9, and 12 months, although there were no other differences at any other time point. So the longer-term implications of having some slightly higher weight gain for the mixed breastfed infants isn't something that carries on or is of a concern as children grow. And I actually didn't go over it, but in the PICO on the previous slide, there was many other outcomes that were assessed, and maybe we'll just go back there for a moment. So there were many other outcomes, including other morbidity, mortality, micronutrient status, neuromotor and cognitive development, asthma, allergic reactions. So many things were evaluated in this study, and overall, aside from the ones that are now listed on the conclusions, a little bit more weight gain for the MBF, and then lower GI, otitis media in the EBF, as well as higher hemoglobin concentrations. There's no other differences between these two forms of feeding modalities for children. Sure. So we're now just going to take another moment here to do a second poll. And I would like to ask you, what do you consider to be the most important piece of information this summary statement has to offer? So in terms of the findings that we've listed so far, what is most important to you? And we're just going to give you a moment to comment on that. And we see some responses coming in now. So it does seem to look like this is interesting. I feel like we're watching polling from elections, as we've been having a bit of experience with that lately. So it does look like the lower risk of GI, gastrointestinal infections, does seem to be most important at this point for most of you on the phone. Although the close, not too far behind the weight for age, no difference in the weight for age at the various points up to 12 months, also important for many of you, as well as hemoglobin. Okay, so if we just now focus on general implications. So what we're always trying to figure out is these are findings, but now what do you actually do with that in public health practice? How does one take this evidence and think about what it means and what one should or should not be doing or developing in public health as a result of this? And so the high-level implications that we've come to as a result of these findings is that in developed countries, public health messages and programs should promote awareness of the advantages of exclusively breastfed compared to mixed breastfed, such as the lower risk of GI infection and otitis media and higher hemoglobin concentrations. But that that we also should ensure awareness that mixed breastfed children result in greater weight gain, slightly greater weight gain than exclusively breastfed infants during that 3 to 8 months, and also a slightly higher weight gain 6, 9 to 12 months. But that there's no other significant differences between these two feeding modalities on all other infant outcomes. So I feel in order to give a full picture of both exclusive breastfeeding and mixed breastfeeding, these are the kinds of comments, statements that one could make. We also think a second point is that public health decision makers should prioritize efforts to ensure high-risk populations are made aware of the advantages of exclusive breastfeeding as stated above. So we have also a question that talks about, can you clarify the length of exclusive breastfeeding for the outcomes stated to be significant? So thank you for your question, and what is important to comment here, and I'm also going to take you back again to the previous slide that gives us some, under the PICO, gives us some greater clarification there. So exclusive breastfeeding, as it was defined in this review, included the provision of water, teas, juices, or small amounts of infant formula, whereas mixed breastfeeding included juices, formula, other milks, other liquids, or solid foods. And the exclusive breastfed infants were exclusively breastfed for 6 months, and that was compared to infants that were exclusively breastfed for 3 to 4 months and then switched over to mixed breastfeeding, which included still some breastfeeding and then other forms of liquids and foods introduced at that point. So I've now moved you into, we've given you a recap of what the overall evidence was and overall implications. And now I've moved into looking at specific interventions and what the evidence said. So this would be now continuing on to the evidence table in the summary statement. So what we have highlighted here is when we look at weight gain, which are results that are analyzed and synthesized from 4 studies. So 4 studies looked at weight gain at 3 to 8 months, and we saw that there was the mixed breastfed children, infants, had, it was statistically significant, small increased weight in comparison to the exclusively breastfed infants. What we also see there is weight for age. Evidence comes from 2 studies, and we see that in the comparison of exclusively breastfed infants to the mixed breastfed, that again, we see, not again, but we do see here that the exclusively breastfed infants have a little less weight for age at 6, 9, and 12 months in comparison to the mixed breastfed infants. What is important to point out here, and the author does this well in the review, is to some discussion about is this an important finding, particularly in developed countries, and does gaining more weight or having more weight for age, is that a good thing? And the author doesn't actually come out and say that that necessarily is a good thing. They're just pointing out that that's what we see here. However, beyond these time points, we don't actually see any differences. Prior, after 12 months, we don't really see any significant differences in weight, whether the infant has been fed exclusively breastfed or mixed breastfed. So implications for policy and practice. Public health activities should acknowledge evidence indicating that the mixed breastfed infants gain slightly more weight than exclusively breastfed infants at 3 to 12 months, although there are no differences in weight gain at any other time point. So do we have a question that we want to address here? So just give me a second here while I look for, while we're pulling this up. So the question is, can you please clarify again the author's definition of exclusive breastfeeding? Did it include those other substances or exclude? Does not seem to fit the current definition of exclusive breastfeeding. So again, if we just want to clarify, what the reviewers are doing is synthesizing what exists in the literature. I'm not sure that, I wouldn't necessarily say this is Kramer's definition of what exclusive breastfeeding is. What they're reporting on is what was found in the studies. So I'm going to take us back again, just so that I have it in front of me. So just to, sorry, I'm a little disjointed because I'm getting different pieces of paper in front of me. So just give me a moment here. If we look again at what we have for our PICO, what was the studies included in this review? It included in their definition of exclusive breastfeeding to be up to 6 months, had breastfeeding plus the provision of water, teas, juices, or small amounts of infant formula. And mixed breastfeeding was defined as, or in the studies in this review defined MBF as included juices, formula, other milks, other liquids, or solid foods. Now I'm looking at the review right now, and on page 4, I don't know if any of you actually have been able to get the full text of the review, states after they define that although the World Health Organization defines exclusive breastfeeding as breastfeeding with no supplemental liquids or solid foods other than medications or vitamins, few studies strictly adhere to the WHO's definition. So that is important here in terms of it's basically, you know, we're doing something with the evidence that's available to us. This has been an exhaustive search to find the studies that have been evaluating and exploring this issue, and this is what the evidence base has for us. So I guess what we have to do is think about, and in terms of applying this to practice, at the end of the day, is this too different from our system here to make this worthwhile? So now I see that someone would like to make a comment, so we're going to open up the mic. And it's Mara. Can you, are you able to talk, Mara? Sorry, just give us a moment here while we're looking. Maybe you can just chat us, Mara, and let us know, are you trying to talk and we're just not hearing you? So we're just working through this. Okay, so can you go ahead now, Mara? No? Okay, so maybe while we might be able to just keep trying to troubleshoot that while I move on, and if not, perhaps we can get you to write your comment down. Okay. Oh.
Hello?
Okay, go ahead. Are you there, Mara? Okay, so we hear.
Hello?
Okay, so I'm seeing that
Hello?
Yes, we can hear you, Mara.
Yes, we don't know. You've already answered the question, as we didn't realize how to do this.
Okay, thanks very much. So the question's been answered, and we will move on. Okay, so I'm just moving us forward again. So we've looked at weight gain and weight for age and implications for policy. And what you will now see here is what would be a typical results table from a Cochrane review. And I think we were going to do another poll question here. And so the question here is a yes/no. Who is comfortable? Are you comfortable interpreting the results of a forest plot, which is what's up on your screen right now? So we're just seeing the numbers, the results coming up. Looks like the no's are winning. So right now it looks like about just under 50% of you are commenting that you are not comfortable interpreting the results of a forest plot, and that's pretty hear that a lot. So one of the things, any of you that actually have met me before or participated in any of the critical appraisal workshops that I've done, this is usually when I start jumping out of my seat and get really excited because I love these forest plots. So let's just quickly break this down. It actually can look like a very scary table, but it's not really so bad. It's not as bad as it looks. What this tells us here is that we have 4 studies that assessed weight gain at 3 months for exclusively breastfed infants compared to the mixed breastfed infants. So we have our 4 studies down the first column on the left-hand side. The EDF-N, second column, just tells us the number of participants in those studies that were in the exclusively breastfed group. And the mean weight is the third column. And then we have the MBF-N is the next column. That's the 1 to the 4th column, and that gives us the number of participants in that group as well as their mean. Now when we move into the really fun part, the weighted mean difference, and we have a line going down the graph which ends at 0. So this is the type of outcome that we would actually call a continuous variable. So it's when we think about how we would describe the results of a continuous variable, we would usually turn that into an average or a mean. So weight is one of those types of variables that can be any number. And if we were trying to summarize what the weight of a group looked like, for example, the weight of the intervention group, then we would add up all of their weights at baseline, essentially divide by the number of participants to come up with the average weight. And so that's what we're doing here. We're comparing the weight of the infants that were exclusively breastfed to those that were mixed breastfed. And under the first study, AICSN, we actually see a line and then a fairly small little dot that crosses, so we see a horizontal line that then crosses this vertical line that is 0. So very quickly what that tells us here is that there was no difference in the weight between the intervention and control group. The line, the dot in the middle is the actual effect size that they found, and then the line that dot runs through is the 95% confidence interval. So in other words, if we reran this study 100 times, the answers we would get would fall in between anywhere on that line. And if that small line crosses the vertical line of 0, then that tells us that there's no significant difference between the 2 groups. The other way to look at that is at the very last column, we see the weighted mean difference with the fixed, the 95% confidence interval. And what we can see there is at the low end of the confidence interval, the -50, and then the high end of the confidence interval goes to 170. And so this is actually giving us the range. So the weight went from less than the control group to more than the control group. So when we have our numbers crossing 0, then that's when we know that the study did not have a significant effect. And I'll just come back one more column now to the one that says weight with a percent underneath it. And what that tells us is how much influence the results of each study had on the overall finding. So at the very bottom, it doesn't really look like a diamond, but if there was a different scale, it would have a diamond at the bottom. That's the actual number that has now represents the results of these 4 studies. And the weight percentage column tells us how much influence each of those studies actually contributed to that overall diamond. So we can see here that the Kramer 2000A study contributed the most influence to the overall number, followed by the WHO 1997 and then the WHO 1994, and that the AICSN had a very, very small influence on the overall finding. So generally what we see here is that there is a statistically significant difference in the weight gain at 3 to 8 months. I'll direct you to look at the actual numbers that are bolded at the bottom. of the scale. So we actually see a minus 12.45 and the confidence interval ranging from minus 23.46 to minus 1.44. And I believe this is grams per month. Okay, so here we have two questions. I'm going to get to those in just a moment. And so the important thing to look at here is in that final, in the final row there, the bolded row, the fact that we actually have negative numbers that don't cross 0, the line of no effect, tells us that there is a statistically significant difference between the MVF infants and the EVF infants, but at the end of the confidence interval, the minus 1.44, that is almost, it's very, very, very close to 0. And so this, while it's statistically significant, is a very small difference. Okay, so I see that we have a couple of questions. So the first question here is, should the discrepancy between the author's EVF definition and the WHO definition not be flagged in the implications for public health practice? That's, thank you. That's a good point to make, and is something that we can look at adding to the summary statement. So thank you for that comment. And there is one other question. At what other age points was weight gain assessed? Do we know anything about the long-term impacts of higher weight at 6, 9, and 12 months? So I don't believe that this study, the review, well, let me just see here. We only have, the results are only presented, which likely means that in the studies included in this review, only presented data for comparing weight at 3 to 8 months. Some compared 6 to 9 months, and others compared 8 to 12 months. And they tried to make sense of bringing this all together. We don't have any other time points other than these that have been assessed in the primary studies included in this review. So it might have been, I'm going to have take us back again to the PICO question. They haven't defined for us very well if they only were looking to 12 months. Which means they might have not necessarily searched for primary studies that looked beyond 12 months. So there could be other studies out there that looked beyond 12 months, but that wasn't the focus of this review. And just having someone looking right now to see, that would be my sense that this review is focusing on up to 12 months. But we're just checking the review right now, and we'll come back with an answer to that shortly. Okay, so I'm going to move on from the weight gain forest plot and now take us to, this is another example here where we did not see an impact comparing EVF infants to MVF infants on weight gain at 8 to 12 months. So this was a different set of studies. There's 3 here. And what we actually see when we look at the forest plot here is when they compared weight gain at 8 to 12 months, overall we do not see a difference between EVF and MVF infants in this review. And we can also see here that the final bolded row, the confidence interval includes 0. We go from a negative number to a positive number. And one of the things that we also like to see in a forest plot such as this is that the results are fairly consistent from study to study. So all 3 of those studies, the impact of all 3 of those studies are relatively similar, which we like to see in forest plots like this, because then it makes more sense to actually be, for lack of a better word, averaging out those findings across those studies. So some of you may be familiar with the term heterogeneity, and that's where we assess whether or not the findings across different studies are similar enough that it makes sense to actually try to summarize them into one overall answer. And so this one looks pretty good. If we actually go back one to the previous forest plot, again, we have fairly similar results. We only really have two actually end up having results on the positive side, and 2 on the negative side, or favors MDF. But again, when we eyeball these results, it seems reasonable that they actually combined them. Okay, so we have one more question here. Okay, so we have a comment here from Lori Greco, our knowledge broker, that says there were no measures of weight gain for infants over 12 months in the studies in this review. So we were just searching for that, and of the studies that were included in this review, none of those studies had as an outcome weight gain beyond 12 months. So again, that's very important in terms of applicability of these results to your practice here in Canada, in terms of this might not be the only evidence that would be required. You might need to be looking for additional evidence, whether that's from systematic reviews. If not a systematic review, then looking to some primary studies to see what we know longer term than 12 months. Okay, so we're now going to move on to gastrointestinal infections. So one of the things to point out here is that these results are coming from one study. So they're, the important point here is there was one study that met the inclusion criterion of the type of quality that they were looking for in this study. That is important to think about yourself in terms of how much weight one would put into the results. But at this stage, this is the best available evidence answering this particular question around exclusive breastfeeding and gastrointestinal infections. So what we learned was that EBF infants were 33% less likely to have a GI infection in the first 12 months compared to mixed breastfed infants. We see that in the RR, the relative risk, at 0.67. That translates into 33% less risk. And if we were to run this study 100 times, the true answer would be anywhere from 0.46 to 0.97. So if I'm trying to do math in my head, that would be a 54% risk. So 54% less likely to have GI infection to 3%. So another way to think about that is the whole story here that you need as decision makers to understand is that EBF infants are anywhere from 3% to 54% less likely to have GI infection than MDF infants. Another outcome that was pulled out here was on the risk for hospitalization, and there was no difference or no reduction in the risk of hospitalization whether the infant was exclusively breastfed or mixed breastfed. So the implications for practice, policy and practice, is that public health messages and programs should indicate that infants who are exclusively breastfed are less likely to have gastrointestinal infections compared to MDF infants. And we are now looking at the forest plot here for gastrointestinal. And again, this is a study by Kramer. And we can see here, I mean, we only have one study to include here. Hopefully, we might see more studies evolving, and hopefully, since this review was published in 2002, when they do the update, there'll be more studies to add here. But at this point, this is the best evidence that we have to show. Okay, now I just want to look at acute otitis media ear infections. This evidence comes from 2 studies. And the findings of this review tell us that MDF infants were 28% more likely to have 1 or more episodes of ear infections compared to exclusively breastfed infants, which I'm just going to have someone look into right now what the time frame around that is. Is that at 6 months or 12 months? at what time frame. So we're just looking into that, but while I talk about that a little bit, what we do see here again at the bottom of that, the relative risk is the 1.28, so that translates into the 28%. Again, if we were to run this study 100 times, we would find that MBF infants were 4 times to 57% more likely to have ear infections in comparison to the EBF infants. Okay, and so our implications for practice and policy are that the messages and programs, public health messages and programs, should indicate that infants who are exclusively breastfed are less likely to have otitis media compared to MBF infants. And this outcome was measured over the first 12 months of life. So we've just, as you can see now on the next slide of our forest plot. So it is always important to know what the time frame is that was assessed on. So we can see here that we have 2 studies that look at this outcome. Somewhat similar results, actually quite similar results, and when they actually average synthesize those together, we see our effect size of the 1.28. This is on the bottom row, with that 95% confidence interval ranging from the 1.04, which is a 4% increased risk, to the 1.57. One of the things I just want to point out here, this is a good example to talk about it. I think this is a bit of an issue with a new version of the software that does the meta-analysis that was used in this review. You might notice at the bottom on the horizontal axis they say favors EBF and favors MDF. Well, in this instance, favors is not really the correct way to word that, but I mean, what it's basically saying here is that the MDF group had more of this outcome, and this outcome is not a good outcome. So favors kind of imply something positive, but that we have learned from the author was something to do with a new version of the statistical software, and we would expect these tags to be more appropriate in the updated version of these reviews as they emerge. Okay, so let's just move on now to our overall considerations. So again, the conclusions from health evidence is that this evidence included, this is a very well done review of weak and moderate methodological quality studies. So I think it's important to reflect on that for a moment, in that generally across the world, the research that's being done in this field is not, answering this question is not extremely rigorous, and there actually is not a lot of it there. It doesn't mean that this review is not well done. This is a very, very rigorous systematic review, but the quality of the evidence in the review is not high. So we need to be careful then in terms of how we interpret the results from that. Doesn't mean that we can't use them, it's just that we need to have that in the back of our mind, that when the rigor of primary studies goes down, then sometimes we tend to really overestimate the effects of what we're actually seeing. So this is, again here, just a recap in terms of the EBF infants had increased head circumference, had higher hemoglobin concentration, lower risk of GI infection, lower risk of otitis media, and tended to crawl earlier. Today what we did, because we only have a 90-minute webinar to present both of these 2 reviews, we haven't pulled out all of the results in this review. Those of you who have read it will know that there's many, many, many outcomes reported on in this review. These were the ones that we felt were the most important for people to know about. And that we do see, while we do see statistically significant differences in weight gain up to 12 months, these are relatively small differences, and we need to think about whether or not they're actually really clinically important differences. And we've already at the beginning talked about what the general implications, but that we would want to give an overall assessment the benefits of exclusive breastfeeding as they've been found here, as well as making sure people are aware that the MBF children do tend to gain slightly more weight than EBF children up to 12 months. Okay, so I'm just going to ask there if there are any questions, and I might suggest that we do them all via chat, or will we take any? I'm a little worried now to go to the mic. I'm not sure that was working so well before, so if you have some questions via chat, please ask them, and we'll work our way through addressing them. You can also raise your hand, so if you click on the hand icon, which is on the right-hand side, we can see it, and we will know if you've put up your hand and would like to ask a question. So I'm just reading one of the comments right now. So we do know that that the comparison of exclusively breastfed compared to some exclusive breastfeeding plus supplements after 3 months, then that might actually have shown larger effects than if there was just a straight comparison between the exclusively breastfed to MBF from birth. So it's the issue here that came out in the text of the review that in some studies there was additional supplements happening as well, and that might have been contributing to some of the differences. So again, not highlighted in the summary statement, but this is the additional detail that one might find important when really thinking about how to use these results to inform practice. So I don't see that any other questions are coming up right now, so I'm going to move now right into the next summary statement, which is Kramer 2003, which looked at energy and protein intake in pregnancy, evidence and implications for public health. And again here, when we look at our PICO, the PICO tells us this is the population were pregnant women. The intervention was nutritional advice to increase energy and protein intake, balanced energy protein supplementation, high protein supplementation, isocaloric protein supplementation, and energy protein restriction in overweight or high weight gain women. And this was being compared to usual care, and the outcomes that were looked at were dietary intake, gestational weight gain, pregnancy outcome for the fetus, including stillbirth, neonatal death, fetal growth, gestational duration, and outcomes for the mother, including complications of pregnancy, labor and delivery, postpartum, and postpartum weight retention. Again, this was a very well done review. It received a quality rating of 9 on a scale of 10. And you would be able to, if you're on the site, click on the link word here, and you'd be able to see our assessment, of that. So in terms of the overall implications, again, what I need to stress here is that this is a very well done, very rigorous meta-analysis that is based on the results of low quality studies. So when the individual studies, the primary studies in this review were assessed themselves for their quality and how well those studies were done, they were judged to be of a low quality. Therefore, our confidence is somewhat diminished in the findings. However, this is all we have at this point in time, or in 2003. So again, it will be very useful to see when the update comes out what else has been published and whether or not that's having any changes in the findings. Overall, what we found was that balanced energy protein supplementation improves fetal growth. It may reduce the risk of fetal and neonatal death. It's equally likely to have very minimal to a very large impact on preterm birth. So in other words, another way to say that is that the confidence interval around that finding is actually quite large and therefore might not be all that helpful to you as decision makers, because it's equally likely that you could get a very good outcome or a not so good outcome. There was no impact seen on gestational diabetes, preeclampsia, and growth and development, and may result in possible harms, for example, reduced fetal growth. In terms of the overall implications, public health programs should include nutritional advice to women, but likely not as a sole strategy, and that this strategy should encourage balanced energy protein supplements. Public health programs should not encourage the isocaloric protein supplements for pregnant women, high protein supplements, and/or energy protein restriction for overweight pregnant women. And then finally, that last caveat in terms of using these findings carefully because of the quality of that data. So if we look at nutritional advice to increase energy and protein intake, we find here that the results said it was effective in reducing the risk of preterm birth by 54%, with the true risk reduced from 2% to 79%. So again, that's the 95% confidence interval there. If we reran this study 100 times, we would find that the true risk for preterm birth would range from 2% to 79%. And that's what I was talking about earlier in those overall conclusions. You know, definitely we would want to implement this. You know, if our effect was a 54% reduction, we're even happier when the reduction is 79%. But when we get down to having an effect only on 2%, so preterm birth reduced only by 2%, one might think more carefully about whether or not you would introduce, you would provide that nutritional advice for that particular outcome. Implications for practice and policy. Public health organizations should not include nutritional advice as a sole intervention. And public health messaging should emphasize that increased energy and protein intake is associated with a decreased risk of preterm birth. One of the things that we found here, and I'll just point it out, some of you, if actually go back one slide, we see down here at the bottom a note, the results presented our own interpretation for increasing energy intake. And we actually interpreted some of the forest plots a little bit different here. And one of the findings reported was that the nutritional advice resulted in a significant increase in, trying to think of, find my data here, in an increase in, sorry, just a moment here, the intake, the energy and protein intake by women. So the result of the review, the author is saying there was a statistically significant increase in the energy and protein intake of women, whereas our interpretation of the forest plot is that it was not a statistically significant finding, although we did see an increase in that. It wasn't statistically different from intervention to control group. So what you see here is this was an overall slide that is showing you the meta-analysis results for multiple outcomes, and we see highlighted in red here the results. This is coming from 2 studies, the number of participants, 449 women, and the risk of preterm birth at 54%, and we see the range. Okay, so now let's look at high protein supplementation, and the evidence here said that when women were encouraged to eat a high protein supplement, there was actually an increased risk of small for gestational age. This was an increased risk by 58%, with the true range, with the true risk going from 3 to 141%. And then on all the other outcomes, we didn't see any other impact on all the other outcomes. So our implications for policy and practice: public health programs should not promote or provide high protein supplementation, as it has no impact on most maternal, fetal, and infant health outcomes, and may in fact have an adverse outcome. And again, here we're showing you in the summary table what the actual results were included in the review for small for gestational age. Okay, so now moving on to look at energy protein restriction in women with who are overweight or at risk for high weight gain. And what we found here was this resulted in a small head circumference at birth by 1 centimeter with a range from 0.14 centimeters to 1.86 centimeters smaller. So this is a statistically significant finding, although one, again, might question, well, is this clinically important? But again, something worth noting. So the implications for practice and policy: public health programs should not include energy protein restriction as a means of improving maternal, fetal, or infant health outcomes, since energy protein restriction is not likely to be beneficial for maternal or infant health and may lead to smaller head circumference among infants. And again, now you see highlighted in red that summary statistic here as well. Again, that comes from one study. Relatively small number of participants, 50. However, important that in such a small study, we actually did find statistically significant findings. And there we see our range in the confidence interval -1.86 to -0.14. So again, just to recap in terms of our overall considerations, that the the promotion of a balanced energy protein supplement did improve fetal growth, resulted in a reduced risk of fetal and neonatal death, however, led to a fairly large, while there was a significant reduction in risk for preterm birth or occurrence of preterm birth, that confidence interval is quite wide. It didn't have any impact on gestational diabetes or many of the maternal outcomes, and there was a bit of a worry in terms of some of these other forms of diet in terms of whether or not it impacted on fetal growth. And then just finally, in terms of overall publications, we should include nutritional advice to women, but not as that sole strategy, needs to have other things with it. Encourage balanced energy protein supplements, and should not encourage these other forms of supplements that aren't balanced. Okay, well, those are the overall findings we wanted to present for Kramer 2003. We'd like to open that up to questions now that you have about this review. So again, if you would like to put your hand up, you can click on the hand icon that's on the right-hand side, about a third of the way down, or you can also write right into the chat. I'm going to just talk out loud here as well to Diva and Robin. Can we introduce another poll? So I would like to ask a question of whether or not you found this data on Kramer 2003 helpful, yes or no? So we're just getting that up for you. And just while you are answering that, I think I'm going to ask another poll question. These things that just pop into my head. And the other one is, was this information new to you today? Were these findings new to you, yes or no? Okay, and if I just do a summary of what we found from the first question, did you find this data helpful, So about 50% of you have answered yes to that question. 18% said no, and around 30%. Oh, now we're getting a few more people answering. About 25% haven't answered. And so now we're going to our poll. We're overloading our poll calculator, I hear, but our next question that we will be putting up there is, were these findings new to you? So we're just seeing some answers coming in from that right now. And it's pretty close race here between yes and no. 25% saying yes, the findings were new, and a little over 30% saying no. And to some extent, that feels intuitive to me, given that these reviews have actually been in circulation for almost 10 years. That's actually a good number to actually see a high percentage saying that no, these findings are not new. Okay, well, thank you very much for answering those questions, answering those two poll questions. I think what we were trying to accomplish today, for those of you that have read the review, they are both fairly lengthy, particularly the first one, 2002, quite technical, lots of numbers, lots of confidence intervals, many outcomes reported on, and we're really just attempting to find a way to synthesize that evidence to make it a little bit easier to use in practice. So I don't believe that we've had any questions come in. So I'll just do one final go around to see if there's anything anyone would like to comment on even. Doesn't necessarily need to be a question, it can be a comment. Okay, so I don't see anything else coming up that we would address. Now, one thing I would like to remind you of, a couple of things, is that we will, starting Monday, have a online discussion forum set up at www.healthevidence.ca.forum. You need to log in with your Health Evidence username and password. I believe that if you have forgotten that, you can let us know that, and that your password would be sent to you. If you haven't registered, if you aren't a registered user of Health Evidence, then you would just need to register. It does not take very long. We just ask for a little bit of profile information so we know who you are, and you can register and become a member. And we will be starting the discussion forum. Will start live on Monday at 1 p.m. If you have questions, comments that come up from participating in today's webinar, we would really like to continue this discussion and conversation there. We will have someone moderating the forum. We will also be participating myself in terms of providing some answers, as well as posing some additional questions for you. So we would just like to keep the debate going in terms of how one might use these results in practice. As well, as I'm sure many of you are aware, we also conduct research on knowledge translation strategies. This is one form of a knowledge translation strategy that we're looking at in terms of trying to get the evidence into the hands of frontline decision makers. And so we would really like to hear from you what you thought of the webinar? Is this a useful way to disseminate findings? So we will be, if you do not receive an email from us, please email Jennifer McCougan. Her email address is included here. It's a very, very short online survey. I believe it's 5 minutes for most of you, 10 at the absolute most. We would really appreciate if you could fill that in for us. So thank you very much for your participation today. We have 3 more webinars coming up over the next couple of months. The next one will be on Thursday, November 24th at the same time. The topic of that one is on the social determinants of health. If that's relevant to your area of decision making, we'd love to have you on board, or even if you're just generally interested in the topic. And we hope that you will join us again. So thank you very much. Bye-bye.